disc which was not progressive and was found mostly in the other eye of a unilateral keratoconus or in a families with positive history of keratoconus. I think we still consider a positive family history or other eye of keratoconus in another normal eye that I couldn't touch with any type of laser. That's my opinion. In Holiday in 2008 described as when hotspot coincides between tangential anterior curvature map, which is a more accurate than sagittal map, or posterior elevation map with the bed-fit sphere at the reference surface. Holiday described also form of refractive keratoconus when hotspot in the relative pachymetry maps show a thickness of a point in relation to normal thickness of the same point in percentage. If it's above 5 micron, it's 5%, below minus 5%, whatever. Kleiss in 2009 described form of refractive keratoconus at the fellow eye in a unilateral keratoconus which does not show any clinical findings except for certain topographic changes. This is what we told for the new generation or the undergraduate, an area of localized steepening, mainly inferior, but sometimes maybe central or rarely superior. Inferior superior asymmetry within 1.4 to up to less than 2 diopters. Keratometry value above 47, oblique astigmatism above 1.5 diopter. Anterior segment OCT, sometimes we use it. Many authors reported that the upper mid-peripheral superior nether epithelial thinning and opposing sector thickness asymmetry and decrease in the stromal thickness, central and the nasal part in particular, without evident corneal steepening on the corneal topography might be suggestive for form of refractive keratoconus. It's not that important, but we have to know about it. Also, several studies presented different corneal epithelial thickness profile analysis or multifactorial regression models based on epithelial thickness measurement, topographical, biomechanical, and or aberrometric data in diagnosis of subclinical keratoconus. For my experience in Corvus ST, I used to depend on it. The dynamic corneal response, or the CBI, corneal biomechanical index, we have a shorter applanation A1 first curve and the A1 velocity, deformation amplitude, and the peak distance are higher. The stiffness parameter at a higher concavity. The Corvus gives a lot of data, more than the aura. So we can depend on this. We will show one of the examples how can you diagnose it. Also the Ambrosio relation thickness and the stiffness parameter at first applanation variable were lower in subclinical keratoconus. Also topographic and the biomechanical index, which is a good tool for diagnosis, which is a TBI, differentiate healthy from non-healthy corneas. We can see the stages here. This is the natural ingoing deformation, first applanation, ingoing concavity, highest concavity, the oscillation period, the outgoing concavity, the second applanation, and after the second applanation. These are the snapshots from the machine. And now we can find this is a normal pentacam 4 map refractive with the Ambrosio curve looks normal, but with corneal biomechanical index, it's about 1 or 90, 0.1. This is a definite subclinical keratoconus. Some authors published that the A2 velocity is the best to diagnose subclinical keratoconus. I said we have a lot of things. The SPA1 had the highest accuracy. Others reported that the ARTH for the Vansegura index is the more significant. This is what I depend on, this index. So the deformation amplitude and the deflection amplitude and the whole eye movement, you can see it. And the amplitude between both of them is what we depend on diagnosis on early keratoconus. Recently, about 100 form of refractive keratoconus defined at the normal fellow eye, both topographically and tomographically, of unilateral keratoconus. Many of those showed abnormal CBI, while the other examinations of the patient were normal. Objective method, the CBI, corneal biomechanical index, and the BAD-D, Bellin-Ambrosio deviation index, and the TBI, all in one test like this, screening values in comparison to using the artificial intelligence, screening values in comparison to healthy population in green and the keratoconic in red. So you can compare both the pentacam topographic assessment with the corneal biomechanical index, both of them at the same time. This helps you to diagnose the cases with early keratoconus or silent keratoconus. These are the data we can catch from the Corvus ST, the deformation amplitude, the applanation length, corneal velocity. The machine gives us a lot of data about the cornea. And a new theory that the keratoconic corneas have a pathological decrease in the biomechanical properties. So the new theories say that initiating events could be a focal reduction in the biomechanics. This will result in a thinning as a weaker area strains more than the surrounding stronger area. If you have a weak area in the cornea, the strain will be concentrated about this area, even if it is small, that can be obvious while doing the biomechanical examination, or corneal biomechanical examination. Focal reduction, the elastic modules generates greater deformation for the same load, which lead to increased curvatures. So we can hear from this curve, we can see this is the healthy, it's less than 1, it's mainly 1, and it increases when it changes in the elastic modules and the biomechanical keratoconus, and we have tomographic keratoconus, then we have topographic keratoconus, and we have the clinically manifest by slit lamp keratoconus. So we can see the curve, it's very obvious that how is increasing when you finally diagnose clinically, topographically, and tomographic and corneal biomechanically the keratoconus. Conclusion, CBI, corneal biomechanical index for keratoconus diagnosis was shown to be highly sensitive and specific alone to separate LC from ectatic eyes. CBI might be an additional help to diagnose ectasia at a stage where tomography and topography are normal. Thank you very much.
Great, thanks, Dr. Ahmed. Just one comment, please, if you don't mind. So, what's the percentage of variable figure that coming from CBI? Corvus, when you are compare it to the Bell and Ambrosio, definitely you know that the Corvus, or the audience, they need to know that the Corvus is a machine, depending, as you said, that biomechanics of the cornea, and connected to the pentacam. So it depends on the topography of the pentacam. For bad, it's coming, Bell and Ambrosio, it's coming from the pentacam. But for the CBI and TBI, that's the Corvus doing it.
Yes.
My question is that few patients that I had with the normal, bad, and abnormal CBI and TBI. So I repeat it again. It was variable, unfortunately.
Yes, that's what I mean. It's exactly the solution as you said. Repeat the Corvus a lot of time. Don't depend on only one exam. Even not in the same time, but at least it gives you some suspect.
Yeah.
But if you can catch more than normal exam, so go on, don't worry. So that's what I mean. Pentacam is not more stability in frequent exams, but corneal biomechanical index is still an exam, need to be professional in taking data, and as you said, it needs to be repeated a lot of times. That's good.
So that's one of the important points, especially the repeatability. We need the repeatability examination.
Yes. The message I say, Dr. Safwani, is if you find any problem in the CBI, just try, and you have a normal pentacam.
Yeah.
But if I have a normal pentacam and a normal CBI, so it's a normal cornea.
Yeah.
So if you want to have the final results and the final answer of your question, it's a normal cornea or not, just repeat. Maybe not in the same time. Maybe I can give the patient 1 week, 2 weeks, maybe other causes maybe happen, but I'm sure I agree with you that it's a repeatable exam and it's not only decisive.
Now, the second comment is that you agree with me fully that our definition for the foot frost can be said that the anterior changes, not the posterior changes. Right. We might not get this anterior changes at the time of the examination. We might have only the history, or we might have a suspicion, but there is no posterior change.
Yes, I agree.
So to conclude, foam frost, it should not have a posterior. Once it has a posterior, we will go through another classic, another stage, another issues, which is the subclinical.
I agree that.
Now that's definitely another page.
Thank you.
Great, thanks, Dr. Ahmed. It was a very nice presentation. So we will go through now to our colleague, Dr. Casino. Renato, the third one. Anyway, Yeah, the third one. Casino, he's here? Dr. Casino. Cosmo, sorry. Cosimo, sorry. Please. Your lecture. Sorry, Habibi, Cosimo. Sorry. Yeah, this is because of a lot of issues. The lunch, yeah, you can. But you're athletes, what you can do. So what Dr. Cosimo said, new era of cross-linking. Let us see what we will have in this era.
Thank you for the
Most
invitation.
welcome.
And so you can see here the cross-linking innovation spectrum. We started from Dresden Protocol in 2003. I personally introduced the cross-linking in Italy in 2004 after a fellowship in Dresden with Professor Sperl. And then Avidro developed in 2014 the first accelerated protocol with 30 milliwatt and introducing the pulsed light treatment. It was a very good achievement. Now we have also the standardized nomogram for teen corneas treatment. And the new era of cross-linking is represented by the EPION compensated cross-linking strategies with and without iontophoresis, with and without supplemental oxygen, intraoperative supplemental oxygen. Of course, you know, all the machine adapted to this world of change. And we have a lot of machines in the market to do accelerated, pulsed light, high fluence protocols.
Yeah.
But first of all, you know that early screening and diagnosis of ectasia in children is the key of success, because the clinical decision to recommend a cross-linking is based on the early diagnosis to use this procedure as standalone. So you have patients with good spectacles or uncorrected visual acuity, so you can stop the disease or delay the disease progression without the needing of refractive procedure or adjunctive procedures. You know, cross-linking is not only oxygen dependent. This is the new. We have at least 3 patterns for cross-linking. We have the oxygen-dependent cross-linking, that is the type 2, that is the most powerful pattern. But we may have cross-linking in low oxygen environment and without oxygen. That is the pathway type 1. And the reaction of cross-linking switch from type 1 to type 2 very quickly, in 14 seconds during the treatment, and come back. With the pulsed light, we improve the oxygenation of the treatment, and we switch the reaction from type 2 to type 1. And there is, of course, a mixed type. The type 1 in low oxygen is based on 2 factors. The concentration of riboflavin, so it is directly proportional to the concentration of riboflavin and to the fluence. We are now in the era of high fluence. This is the novelty. Accelerated, this was the first study of laboratory study that showed for the first time, Ronald Kruger, that 9 milliwatt, 50 milliwatt continuous light and pulsed light achieve the same biomechanical efficacy of the glorious 3 milliwatt Dresden protocol. So it was the start to switch through accelerated. Take a look here. We have a lot of protocols now. So cross-linking today is a subspecialty. We can use in different ways according to clinical case. So we can customize cross-linking, and we can combine cross-linking with different techniques. You can see the 9 milliwatt that replaced the Dresden Protocol now in Europe. Not in the States, not in the United States, where only the Dresden Protocol at 3 milliwatt is approved. And we have the pulsed light 18 milliwatt. You can do the cross-linking in 10 minutes, 10 minutes of soaking and 10 minutes of irradiation, 20 minutes instead 1 hour. Pulsed light 15 milliwatt, 30 milliwatt of hydro with continuous and pulsed. Of course, we have the Epion with iontophoresis, riboflavin loading, and without iontophoresis, and with supplemental oxygen and without. The effectiveness of this kind of treatment can be enhanced and has been optimized, adapting fluents, first of all. Then adapting riboflavin solution, increasing the concentration. And with enhancers in the solution, and with iontophoresis, of course, adapting the administration of riboflavin, driving the photochemistry in aerobic, oxygen, and anaerobic pathways. These were the first studies that I published on the pulsed light when it was introduced for the first time, demonstrating that the pulsed light induces a significantly deeper stromal demarcation line and when compared with the continuous light. Not only, but we improve the oxygenation and we induce less microstructural damage to the keratocytes. So we have less AIDS if we use pulsed instead of continuous lights. This was a major review that I published in the ocular surface that demonstrated the different strategy, protocol, and the impact on keratocytes and the depth of treatments. And this was the first study in clinical showing the study of Kruger that was lab studied. It was the clinical one that showed that 50 milliwatts works like 9 milliwatt and like 3 milliwatt in the same way. This is the study that we conducted together with the 3 schools of cross-linking, Dresden School, Zurich School, and Siena, and also with Ashraf Farmia, that is here, collaborating to this amazing project that finally replaced the Dresden Protocol. So you can do now the EPI-off using 9 milliwatt instead 3. So you do 10 minutes of irradiation and 10 minutes of soaking, 20 minutes to do an EPI-off. This is a great achievement. What about the thin corneas? Yes, thin corneas. We have 2 standardized protocols now. We have the M nomogram that was published in the International Journal of Keratoconus and Ectatic Disease in 2018 and was awarded in the ESCRS in Paris with the Joseph Collen Prize, and the sub-400 protocol proposed by Sabine Kling and Afesi group. I also participate in that work. Which is the difference? Both are pachymetry-guided protocols, but the M protocol gives always 5.4 joule of fluence. So maintain constant the fluence independently from the thickness. You deliver the same energy of the Dresden protocol beyond your thickness, your baseline pachymetry. While the sub-400 is a decreasing fluence protocol. Use always 3 milliwatt, 5.4, and decrease the fluence according to the pachymetry. I will show here. This is the sub-400. If you treat a cornea of 250 microns, you give not 5.4, but you give 1.6 fluence. If you treat a 200 microns cornea, you give 0.72, not 5.4. While, if you use this nomogram, that is based at this, a very long-term follow-up, you can treat each ectasia, each pachymetry, changing the UVA power and changing the exposure time, but maintaining constant defluence. 5.4 in any case, so you don't lose biomechanical effect. This is really, really important if you want to stabilize your activity, because our goal is to stop the disease.
Using different powers.
Yes.
To reach
You change the power and the time, but you give the same fluence.
Yeah.
This was the first study I did using very high fluences, 7.2, then 10 joule, then 15 joule in epi-off. You can see 3 demarcation lines. So we showed for the first time that cross-linking is not only oxygen dependent, but also fluence dependent. And endothelium was okay, in any case, so is more resistant than we think. And this was a study that I presented in the American Academy of Ophthalmology in 2014. This is the first study I published using Epion customized with 2 fluents, 7.2 and 10. And you can see also in Epion with supplemental oxygen in this case, with the oxygen mask, oxygen boost goggles, you can have 2 kinds of demarcations. The first is more superficial with 7.2 and the second 10. What's new in the Epion? Epion, we are increasing the riboflavin concentration, From 0.1 of the epi-off, we are going to 0.25, 0.22. We are increasing the fluence. This is the era of fluence. The fluence is the most important if we want to improve the efficacy of this kind of treatments. By 30%, 7.2 instead 5.4, but also up to 10 in this moment. We are using the pulsed light and also sometimes the oxygen. I changed the iontophoresis protocol, enhancing the fluence. And you can see there the demarcation line. It was similar in epi-off. And it was enough to improve the fluence from 5.4 to 7 and to include the pulsed light treatment instead of the continuous light. These were the medium to long-term results published in the Journal Refractive Surgery in 2020, showing that Iontoplas is known. This protocol is the new iontophoresis, or Iontoplas works. And you can see the demarcation line and the reflectivity of the stroma you can see at OCT. This is the last publication I show you that we share with also with Ashraf. So every one of you knows the advantage. So we are working hard for Epion. We want to improve the Epion because we want to avoid infections, we want to avoid AIDS. Of course, we want to do bilateral simultaneous treatment. We have a lot of advantage doing this. We have a lot of protocol. This is an enhanced protocol without iontophoresis and without supplemental oxygen that works. You can see here, we have the same demarcation line. So we use 7.2 joule of fluence, pulsed light, high room oxygenation, and we did the soaking with Paracel 1 and Paracel 2 solution, 0.22 and 0.25 from Avidro. So this treatment may achieve the goal also for a preventive use of cross-linking, also in form fruit keratoconus, suspected ectasia, and in any case you want to do prophylaxis. This is the article that show you in +1 that the fluence of 10 is the better way to achieve the maximum effect when you work in epi-on strategies. You can see in the graphic the red circles and the blue triangles, and you can see that increasing the fluence at 10.8, you achieve the maximum strength. These are finite element analysis biomechanical studies that we did in the Politecnico of Milan University this year. So this is a definitive demonstration that we need to work at 10 joule. The ongoing studies, yes, we are studying now. We are testing everything. We are testing with iontophoresis, without iontophoresis, and with oxygen and without oxygen. Another novelty is the chemically boosted solution. In this solution, we have ethylene diamino succinic acid that improve the efficacy. So we can boost also by chemical point of view with the riboflavin solution. Thank you for your attention.
Great, thanks, Dr. Cosimo. Any comment, any question?
No.
From the audience? Okay, great, thanks. So we will go to our colleague, Renato Ambrosio. Unfortunately, he couldn't make it and couldn't come. So Dr. Ashraf will show his presentation that it's recorded with his voice, and let us see. The presentation for Renato Ambrosio is paradigms and paradoxics on corneal ectasia.
It's not working.
You connected to?
Yeah. It's a video. You want me to put it here? It's a video.
So until we will have, so I have one question to Dr. Cosimo. Dr. Cosimo, you said there's one comment that, for example, changing the influence, you are using 30 milliwatt to reach, let us say, 5.4 in 1 minute. To reach 7.1, you need to increase, you will keep the 30 milliwatt, but increase the time. So that's what I need all the audience to understand, that when we need 10 milliwatt, for example, we are changing the time exposure by fixing the power that we are using. Because here you used 30 milliwatt. For the thin cornea. Yeah, we are talking about the thin cornea. Great, thanks.
We're ready.
Okay, done.
Hello, I am Renato Ambrosio from
Just a voice bit.
We need audio from here.
No, audio is coming. Okay. But you need to change.
Hello, I am Renato Ambrosio from Rio de Janeiro, Brazil, and it's my
coming.
big pleasure
The sound
to
is very low.
participate in the Hello, I am Renato Ambrosio from Rio de Janeiro, Brazil, and it's my big pleasure to participate in the Middle East Ophthalmology meeting with the topic Redefine Foam Flux Keratoconus. These are my financial disclosures, and I'd like to start with a perspective understanding that keratoconus have evolved tremendously because of refractive surgery. And you can see the number of publications that have on PubMed. We have a huge increase when we had the start of refractive surgery, even incision of refractive surgery, and moreover, laser vision correction. So the need for understanding ectasia and of course the impact of those technologies for the diagnosis, for clinical treatment, for surgical treatment have made refractive surgery a huge ally of refractive surgery of ectasia. However, it's also the enemy. Why it's the enemy? Because we have iatrogenic progressive ectasia after procedures related to refractive surgery. Even before laser vision correction, we had incisional keratotomy with a radial keratotomy and a stigmatic keratotomy causing ectasia. But when we talk about LASIK, the first described cases of ectasia were in 1998. Theo Seiler described first 3 cases of progressive ectasia in patients with very high myopia. And a few months later, he published the case of Foam-Frus keratoconus that had iatrogenic ectasia, and he defined Foam-Frus keratoconus based on front surface keratometric values with inferior stiffening. Interestingly, those 2 cases allude perfectly to the pathophysiology of ectasia, which is related to biomechanical decompensation, considering corneal resistance, and of course, the impact from the environment. Those are the 2 hit hypotheses described by Dr. McGee on the impact from the environment and also the genetics and the resistance of the cornea. So any cornea may develop ectasia undergoing this cycle of decompensation nicely described by Cynthia Roberts and BJ Dupes. Interestingly, if you want to have patients to avoid ectasia, start by telling them not to rub the eye. We know that the misinformation makes the patient suffer even more than the disease, and that's the soul of the Violet June campaign. But if you think about eye rubbing, it can aggravate keratoconus or even cause ectasia. Those are not exactly the same thing. Interestingly, when you think about ectasia risk assessment, we have the ectasia risk assessment by Brad Rutherman and colleagues in 2008 that the topographic pattern will be very important for understanding the ectasia risk. But my major concern is that Foam-Frus keratoconus should not be a topometric pattern and should not be an abnormal topometric pattern. Moreover, we'll discuss about definition of Foam-Frus keratoconus. But interestingly, in this very nice work, we had age, which is a surrogate of corneal biomechanics, coming as a very important factor for ectasia risk assessment. Interestingly, in this nice series from Dr. Schauhorn, with over 300,000 LASIK procedures performed in 2007 and 2011, you have cases with normal pattern, even normal tomography, that had ectasia. So if you had the green is the ectasia case, you have 30% of the ectasia cases with a normal pattern. Interestingly, there are patients with so-called Foam-Frus keratoconus with abnormal tomography. You see, this patient had a stable LASIK with more than 4 years of follow-up. So interestingly, we need to go for enhancing sensitivity and specificity when we screen for laser vision correction. So what is Foam-Frus keratoconus? First, the Foam-Frus is something that we have from ophthalmology from the work of Mark Hemsler that published the Foam-Frus on Javal, and after that with the keratoscopic with a longitudinal study. And interestingly, a few years later, before then, we had many Foam-Fruses in medicine, including Foam-Frus psychosis by Sigmund Freud. So Foam-Frus is an attenuated form of the disease, is a subclinical form of the disease that may progress or not for the form plane, which is the full-blown form of any disease. And Yaron Rabinovitz would say that a Foam-Frus keratoconus is a patient with abnormal topography in normal distance correct vision in a patient that had abnormal topography. So this will be the right eye of this patient. Interestingly, in a very nice editorial from 2009, Steve Kleiss would give us the definition of Foam-Frus keratoconus as a fellow eye from patients with asymmetric. And those are the definition that I prefer, the very asymmetric ectasia cases. In a systematic review, Dr. Enriquez and Luis Izquierdo from Peru, they did a very nice work on the literature, reviewing the cases. There is no consensus in the literature. It's also, there is no consensus on the consensus that we had, the global consensus. And so we have an incomplete form of the disease by Amsler, the mild keratoconus by Krashmer, the fellow eye with clinical signs from patients with very asymmetric disease, sometimes calling unilateral, by Steve Pleiss. And my humble contribution here is that form flu should be defined as the cases with high susceptibility for ectasia progression. And we first coined that in the academy in a paper in 2008. Interestingly, that time we were talking about cases like this one that had a relatively normal topography, had LASIK with a residual stromal bed higher than 300, the PTA is lower than 0.4, but the patient developed ectasia. Many people, when they see that they had ectasia, they will say that this little yellow in the Steve Pleiss 1.5 diopter scale will be like a very abnormal sign. But when we do that, we look at the objective ways, we can say that in the Bell and Ambrosia, we have the D score that's in the yellow zone and also an Arcmax that is lower than 400. So this is the cutoff values that we have for ectasia susceptibility. We're not talking about mild keratoconus. This patient had 20/20 plus and this was correct vision prior to LASIK. Interestingly, in the larger series, we have the BADD, the version 3, with a cutoff value of 1.5, having a sensitivity of about 60% for the pre-op of LASIK ectasia cases, comparing with a pre-op LASIK stable case of 3,278. So in the IS value, this is very specific because the doctors are very much obeying the rule for curvature. But here you have a very low sensitivity if you look for the abnormality on topography on the IS value. Interestingly, the BADD will give you higher sensitivity, but an advanced tomography pattern detected by AI, very nice work by Bernardo Lopez, we will have the PRFI, the Pentacam Random Forest Index, with a higher sensitivity than the BAD-D. However, we have cases that we need to go beyond that. And our idea is to enhance our understanding looking at biomechanics. So the dynamic Scheimpflug imaging that we have here, a nice demonstration of keratoconic cornea and a normal thick cornea, you can see the deformation response, and we look at the parameters, the deformation amplitude, we have the velocity, the shape of the disc, and all of this can be combined with the cornea biomechanical index or the Corvis biomechanical index. Very nice work by Paulo and Ricardo Michiguera. So we can separate a softer cornea and a more stiff cornea in this scenario. So we combine with artificial intelligence, with a random forest, with a strategy for cross-validation, live or now cross-validation, and this is what we have in the JRS paper 2017. So we have 94 cases with very normal topography based on a strict criteria, including the fellow eyes that were not operated, 204 keratoconic patients, only one eye randomly selected by these patients and also from 480 normal patients. And we had a very nice separation for the clinical keratoconus and a very relatively good sensitivity for those cases. So what we have here is a surrogate of corneal biomechanical structure. So we have cases like this one, 27 years old, 2015, this is correct vision, normal topography. The tomography is not abnormal, but when we see the TBI is higher than 0.3 and this is abnormal, so we can confirm based on this data that the fellow eye of this mild keratoconic patient that, by the way, had a 2025 this is correct vision in the fellow eye, this is foam fruits keratoconus is the very asymmetric normal topography eye that we can confirm with advanced analysis. Interestingly, we have cases like this one. This was published in the International Journal of Keratoconus and Ectatic Corneal Diseases. We have a normal topography, a normal tomography, and uncorrect vision better than 20/20. This patient had a keratoconus pattern in the right eye and had a great result with corneal rings. This patient was transferred by his work to London, and I had Dr. Renstein, Professor Renstein, with his great prolific examination, including epithelial thickness, the Damian-Gatineau score from OBSCAN, all coming normal. And retrospectively, we look at the tomography data and biomechanical data. This is zero in the unilateral ectasia, not keratoconus. And this patient even came after a few years for a follow-up, he is still very stable in the right eye. So the global consensus can come with unilateral keratoconus does not exist, but you can have secondary ectasia in any eye due to a purely biomechanical process, and that can be unilateral. Even I can say that
So I
polyfused
think that
keratoconus
we
can
need
occur
to
in
finish
both
that
eyes
because
of the
the
same
time is
patient. This is
over.
a twin sister, and this is the
Yeah,
topography from the
we can stop
Placido, the
it.
topometric evaluation from the Scheinfeld, pretty much the same data, and the TBIs
Yes,
are known in the
that's
four
okay.
eyes. And this first twin.
So great thanks for our colleague Renato Ambrosio for this comprehensive review. And now we will ask our colleague, Dr. Ahmed Saadi. Dr. Ahmed Saadi is a consultant ophthalmologist, cornea refractive in Zayed Hospital. He's our colleague and close friend for me personally. And he will talk about the phakic IOL in keratoconic. He likes phakic IOL a lot.
Yeah, if you can, please, kindly.
So in this live surgery, from all, I could recognize your voice, Ahmed. Right, Ahmed?
Where is that, Doctor? Hi there, good afternoon. Thank you very much for the introduction, Dr. Safwan, and the panel. I'd like really to appreciate really the invitation.
Yeah. I said that from all our colleagues, I recognize your voice. It's a very, very unique voice. Yalla, Habib.
Okay, so good afternoon. I'd like really to speak about fake intraocular lenses. Yes, I do like them, but no financial. I have no disclosure related to this talk. So keratoconus is a common disease, especially in our region. In a recent paper published by the group in CCAD, they found that the prevalence of still play it now. It's just changed now, see? It keeps coming, the same thing. But it's okay. No, usually it doesn't show like this. This one. Doesn't come. Usually I don't sit.
It's fine, Dr. Ahmed, because the time.
Here, I think it's going there, and my view is the regular view. What I'm supposed to see is going there. Anyhow, so I'll go back. So I will be speaking about the phakic intraocular lenses in keratoconus, and I declare no financial interest related to this talk. Keratoconus is much commoner than what we think. A study conducted by Cleveland Abu Dhabi group showed that the prevalence of keratoconus in the school boys and girls is about 2.7%, and the form-fruit keratoconus or the suspected keratoconus is close to 20%. So this is really a huge number, and as been mentioned earlier, it's very important to look at this. There are so many, because I've been asked to speak about the phakic IOLs, there are so many treatment options. And when it comes to treatment options, there are those glasses which can be really thick, and when they are thick, people might not like them or they might not enjoy the vision. contact lens with different types, whether it's scleral, hybrid, but still people are not enjoying it because of the intolerance. Intrastomal rings is another option. Cross-linking with all of this, as well as phakic IOLs, and finally, deep anterior lamellar keratoplasties. Or we can use a salad of all of this. And when we use the salad of all of this, at this time is where the art of treatment of keratoconus is coming. About a few decades ago, there was one option, contact lens, then PKP. Then all of this development came down the road over the last 2 decades. So unfortunately, there is no size that fits all, including all these procedures. We have to keep in mind that patients might have irregular astigmatism. They can have a high degree of keratometry, as well as the high order aberrations. So we have to keep in mind whenever we come to decide whether to use phakic IOLs, we have to think about the other parameters that we should keep in consideration, especially the coma. So we should ask our patients whether they are complaining of high order aberrations like double vision or glare, especially the coma and the trefoil. So I'll just introduce the columnar to you. We need to know that the range of this modality, it can tackle, and it was designed for myopic eyes. It was not designed for keratoconic eyes. But we are using it now more often to correct those eyes. The range is between -3 and -23, and it can correct astigmatism up to +6 diopters. So, coming to manage the power. So when it comes to calculate the power, you need to keep in mind that you are taking the K readings, and the K readings, you can obtain it from different ways. You can obtain it from the autoref, you can obtain it from Scheimpflug, or from your any type of tomographer. Keep in mind that there are different ways. There is the axial, there is the tangential. So there are some errors that can come into the scene here. Adding to that, the posterior corneal power, which is altered in keratoconus. In addition to that, you need to provide the information, and the true formula that we are using, it's not really disclosed fully. We know that it's a modified vertex formula, but the calculator remains owned by STAR. And I tried my best really to find out exactly how does this work. It is modified vertex, or that's all the answer I was able to search, or even reaching that out of the country. Now we go to the sizing, which is another issue when it comes to the sizing. So the sizing takes in consideration the AC depth. It takes in consideration white to white. And the definition of white to white, we know that the cornea or the eye has different white to white vertically compared to horizontally. This is number one. The second thing is the AC depth. When it comes to white, what would be the best modality to measure it? That's the question which is causing most of the explantation. So if you do have a white to white, if you are measuring it by caliper, there is an error, always. If you are using your orb scan or some of the tomographer which can provide white to white, it's another shortcoming. The other thing, some people have used the biometry or the B-scan or the UBM as compared to the anterior segment OCT. And they did not show much difference to see the sulcus to sulcus, keeping in mind that there are some anatomical variabilities. Others tried to use the visible iris. So there are still, I think there is more work need to be done regarding the sizes and the sizing. And then the plan comes as such. And we all know that a rotation of 1 degree can result in 3% reduction in your cell. So a 33-degree rotation will negate everything you've done. And again, you need to utilize a very good alignment for those surgeries. Here is the introduction. All what I need to say that in keratoconus, you can directed. The most important two things to do is the direction of your wound. Don't overfill when you inject, and keep the pressure on your lens while it's going in, so it does not flip. So how effective is the TICL in keratoconus? In keratoconus TICL, Imara and his group, they achieved about 74% of the target refractive error at 6 months. So in keratoconus, it's less effective. On the right hand, I'm showing Dorodgar. This is a publication of which was prospective study, but was not randomized, showed that almost 100% of the patient saw 20/50 or better after keratoconus. But yet, we know that to achieve 20/20 needs to be kept in mind, and the quality. So keratoconus TICL, the one I use briefly, is this. So if the patient is seeing better than 612, and the patient is having the following: K reading less than 55, AC depth 2.8 endothelial, CCT is more than 400, ECC more than 2,000, then this patient, and he is tolerating his high order operations, he's not complaining, then this patient can go for cornea cross-linking, and 6 months later, you can do the TICL. For those who are not seeing really 612 or better, then you can look into them as two groups: candidates for wavefront or topo-guided plus cross-linking, whether simultaneous or sequential. If you have good result, then you can proceed. If the vision is 20/40, then you can go for TICL. Those who have bad results, they end up going either to DALK or going backward toward their scleral contact lens. If the patient was not a good candidate for wavefront guided or topo guided, then you can consider ICR, intrastromal corneal rings. And if they get good result, then you can implant the TICL, which we have done frequently after cross-linking them. If it was a bad result, again, they will go to deep anterior lamellar keratoplasty. And this is what I practice. This is from. There was also a big series came from Saudi Arabia, looking at the outcome for the phakic IOLs in keratoconus and non-keratoconus. And overall, they showed a big improvement, almost an excellent improvement, more than 95% of the target refraction in the non-keratoconus eye, while in the keratoconus eye, most of the patients improved, but still there was some residual, and the numbers are shown. The causes of ICL explantation, I want just to bring to your attention that the volt was the most common, the high volt or low volt. Everybody speaks about a volt of 250 microns to 750 microns, but you have to keep in mind, anything below 150 you have to explant because it will cause cataract. If it's less than 150, don't do it, just explant it with something else. And keep in mind that the cataract will develop, and as well as the refraction. In keratoconus, there are more refractive surprises compared to non-keratoconus. So the take-home messages: phakic IOLs, Vizan talking about, are effective and safe in keratoconus, can be used as single method of treatment or can be mixed with other options to achieve visual rehabilitation in keratoconus. High order operations might be an issue despite the refractive result. And the most common cause of explantation is the volt due to sizing issues. Better method for precise sizing is still to be found. Thank you very much, and I'm ready to answer any question.
Thanks, Dr. Ahmed. And I have one comment, a comprehensive presentation, but there is one comment that we need to say. What's the sharp cut for your side or your opinion that we need to implant an ICL for a keratoconic patient? After what, or what's the time after the stability of the
For me, 6
cornea?
months.
Cross-linking or, sorry?
For me, 6 months.
Wow, 6 months.
Yes, I wait 6 months. If the patient is stable, I go with it. Yeah.
Okay. So,
Especially, I personally don't practice epi on. In these patients, I always practice epi off.
yeah, no, we are talking about classical epi off.
Yeah, epi off. Yeah,
Epi off and 6 months.
6 months.
Now I'm waiting for 1 year, and I have patient of regression after 1 year.
Well, I agree. The chance for any cross-linking, we know that
For
cross-linking is successful in 93%
So-
of the patients if we follow them up to 7 years. 7% will still
Exactly.
regress.
Especially
But
for the
my
low
chance-
age. Low age. Those with from 20 to 25, they have a higher chance than
Well,
others.
I think I agree with you. There might be some people who would like to wait longer, and
Yeah.
this is but I'm not aware that there is a very strong evidence that it might change. But it's a very valid point. I
So,
take your
second
point
question is that what you will do,
for.
you have a patient, you wait for 1 year, it was very stable, patient very happy with the glasses, with the spectacles, you decide to do an ICL and you did it. And after 1 year or 2 years, he returned back to you with a regression.
I did ICL already. TICL.
Yeah, for sure, ICL in. 1 year, 1 year stability, patient was very happy.
But still, okay. So you have to cross-link them again, and these patients you'll keep following them up closely, especially at the first 2 years. Though I think I will cross-link them again. I
Yeah.
will not explant them definitely unless it's causing high pressure, cataract, or high volt, and because I'm quite confident that this patient has improved a good amount. So cross-linking again is advisable. You can re-cross-link
Yeah.
them, especially what is your definition of progression? Are you talking about one diopter of care reading? Are you talking about change in cornea and corneal thickness, or are you talking about change in a Poussier float?
You know
So
that
it depends how.
I'm
how we
following a
look
lot
at it.
of protocols, so all the nomograms that you are thinking about it, it's there. It's change. Thickness, thinning, K reading, more than 2.5 diopter, and the astigmatism changes, and the visual acuity changes.
But what is your start point? Is your start point you are comparing today with the pre-cross-linking, or are you comparing it with the day of when you implanted, when you thought they were stable? So again, here
Patient
we can
have from 6 months regularly every 6 months. So every 6 months
Where
we
is
are
your
reading,
start point?
and
You
there
are
is a
comparing to
review
what?
for the last 1 year. Start changes, and this
understand,
changes.
but the changes, are you what is your, so the changes, the one, let's say you hit those numbers, when did you hit them compared to when you implanted, or because after your wound you create wound of 3.2, so you might induce astigmatism again, your anterior float might change.
I
in my
understand that.
opinion.
So we have a record on a Excel sheet showing all the data from the start to the end.
Whatever it is at that time, I'll do cross-linking. If the patient is progressing, I'll do cross-linking again.
So I did, and what I aimed, flattening.
Flattening. Well, flattening is expected in some.
Exactly.
There are
So
enough
here
reports.
I shift the story to hyperopic shift.
Yeah, I see.
Yeah.
So you have to
Now
explant.
the question is that my decision is then definitely we did a thorough examination. We are doing a thorough examination, especially when there is a shift. The shift, especially in post cross-linking, it might be related to the lens. And that shift, myopic or hyperopic, and that was what I'm expecting. It was corneal changes that's right, flattening, but the cataract that we have it as a posterior subcapsular cataract, it was the one. So definitely we solved the problem here. The decision is very clear. So the cataract solved the problem. So
Yeah, then
but I
you
do
remove
agree
the
fully with
cataract.
you with this is the strategy, how we are following the patient after the ICL. Great thanks. Sorry.
Yeah. Take the history, take the stage from you did the cross-linking for the patient. So it's an epithelial on or off? Off.
For me,
So at least the first 3 months the epithelium to return to normal. So we are not going to rely on the pentacam in the first 3 months. So it's only 3 months for 6 months. So you are going to do a pentacam after 3 months, actually after 3 months, and epithelial mapping for sure to detect that the epithelium is already refashioning again. So if we wait for another 6 months, to do another pentacam and epithelial mapping, it's okay. To do a ICL, before the ICL, do you try hard contact lens or contact lens first to make sure that the patient with the contact lens is going to see better, or you go directly for the ICL?
Well, for the patients, definitely, I don't jump to TICLs. I mentioned earlier, patients might be intolerant to contact lens. They might see excellent. We all know that anybody with irregular surface, they will never have a good quality of vision like they do with hard contact lens. So this is always, I'm talking about now beyond this, whether the patient is intolerant or the glasses are too thick. So definitely contact lens comes earlier before the decision of going for ICL. Once we go to the ICL, then I know that I have exhausted my conservative measures. That's why I've mentioned that those would be early.
I mean, if the patient see well with the contact lens, so you are going to with the ICL. But
One indication might be this, definitely. Other indication, even glasses, some people are intolerating their glasses because they have a high astigmatism of 6 diopters or anisocoria, anisometropia, all of those. But this is not my first choice.
So great, thanks, Dr.
Thank you,
Dr. Ahmed.
Thank you.
And we will go to
Thank you.
Dr. Ashraf Armia, our colleague Ashraf Armia. And he will talk about the cataract that we talk about it. Cataract surgery in keratoconic patient. That's a little bit challenging, Dr. Ashraf.
Yeah.
Do you think, Dr. Ashraf, if patient get better with the hard contact lens, a better vision with the hard contact lens, he will have the same vision in ICL?
Yeah, this was the aim of my question to Dr. Ahmed. So
I will take time from him, not from your side. Yes, please.
If it's hard contact lens fitting good and the patient going to see good, so the retinal image will be okay. So I'm going for ICL. But if he tried the hard contact lens and the vision was not improved, so he's not going to improve with even the ICL.
Yeah.
This is the aim of my question. Yes.
That's right.
Yes.
But we need to know one fact that the hard contact lens vision, the vision that obtained by hard contact lens will improve all the high order abrasions, everything. So that will not be the vision that he will gain it when we will put the ICL.
Yes,
that's totally different. Well, that's what I'm saying. The vision in the glasses that you have is the same vision that you will have it. Especially here, we can correct the high astigmatism.
Yes.
Yeah. Yes, please.
Before I start this presentation, it's a debatable presentation, and what I'm going to say is going to be debatable forever.
No, we need to know your experience, Dr. Ashraf.
Your
Your experience, my dear.
Because every time I do a
the
presentation on
expert.
this issue, it is a debatable presentation, okay? So I don't have any financial disclosure, but these are my company that I'm consultant or speaker to them. So if we look, we are going to find that although nearly all patients will eventually develop visually significant cataract, this trend to occur in younger age in patients with keratoconus compared to the general population. And this was approved by this study. It was in 2017. And the cataract surgery in patients with keratoconus is challenging due to the difficulties associated with the interpreting keratometry readings, determining the amount of astigmatism, measuring the axial lens, and thus obtaining the accurate IOL and the effective lens position. So, if we think about corneal ectasia, which is keratoconus is a part of corneal ectasia or a steep cornea, so it's a progressive steepening. So, progressive corneal ectasia leading to myopia, irregular astigmatism, wide range of case values in a small area, and this leads to changes in the AC, which makes more difficult to calculate the effective lens position. This is the problem in keratoconus. So, again, corneal ectasia, keratoconus part of corneal ectasia, post-refractive surgery ectasia, it's part of corneal ectasia. They are resemble each other, and so the IOL calculation, we will think in all different corneal ectasia as only one entity. So, if we are looking for stability before you are doing cataract for keratoconus, should calculate the lens when we are confident with a corneal stability, Never calculate a lens in a fluctuating cornea. Advise patients about the small risk of corneal decompensation, which can happen in these corneas because this is not a normal corneas with ectatic progression after surgery. Corneal ectasia is progressing, so you might want to cross-link the patient after cataract. And to rule out the progressing ectasia, we recommend to perform at least 3 corneal tomography 3 to 6 months apart from each other. I stay from 1.5 years to up to 2 years before I do any cataract or even phakic IOL. At least 2 years, because the effect of cross-linking can continue up to 2 years, and some papers said up to 7 to 10 years. So the challenging in this is IOL calculation and the intraoperative tips. This is what I'm going to highlight. Challenging in biometry, 3 basic measures are included in all different formulas: axial length, corneal power, and estimated lens position. So the steeper cornea and the off-centered apex make it difficult to obtain an accurate biometric readings. Why? Because the ectatic eyes have higher axial length and deeper anterior chamber, this making the effective lens position harder to estimate. And as the apex is off-center, it might be not the visual axis. So this means that the corneal case measures at the apex of the cornea might not be the true case that you are going to calculate your IOL. So we have to decide what optical zone we are going to use. And this is the aim of the pinhole pupilloplasty that innovated by Ammar Arpriya to decrease the pupil as much as you can, so you can overcome all these challenges. And allows, and always keep in mind that there is no specific rule to decide how large this zone can be. So this very nice study, it was at the American Academy at the 2017, and the results, it was using the different formulas and using the IQ from Alcon, and they calculated that the overall, the Ballet Universal 2 formula had the lowest prediction error for the 2 IOL they were using, and you are comparing all different formulas in this study. But another study was perfectly show that the patient with keratoconus has this very nice scheme if you want to take your decision. So patient with keratoconus, it was 2019, and they put this very nice diagram. If you have a history of corrected distant visual good, so should look for the manifest. If the manifest and the topographic axis equally, so go for cataract surgery and toric IOL. If the manifest is not with the topographic axis, go for cataract with monofocal, and you can enhance later on with a toric ICL if it needed. If the history of low corrected visual acuity, so you should regularize the cornea because this is an irregular cornea by the ICR, then do the cataract surgery monofocal, and you can enhance by the toric ICL if needed. And the advanced ectasia, so it's no need to do cataract only. You should change the cornea because this is not a normal cornea. So phacoemulsification with implantation of toric IOL has shown to be safe by this last publication, 2016, and also benefit from this treatment, but it should be a regular astigmatism. I'm going to, so this study, it was in 2020, and they used multiple IOLs and different formulas, but in this study, they were using a new formula, which is the Kane formula, and used with different IOLs, and this is how they calculated the different, with the different IOLs, and found that calculated by this Kane formula, and this is the calculator formula by the Kane formula. But to use this, you should put in your mind this table. If it's stage 1, don't adjust choosing the refractive power of your patient. If it's stage 2, make the post-operative refraction from minus 0.75 to 1.5 diopters. If it's stage 3, go for more myopia from minus 2 up to minus 3 to nearly reach your predicted target. So in this very study, it was 2020, the last study about cataract with keratoconus, they said that the Kane keratoconus formula was the most accurate formula in this series. After the Kane formula, you can go for SRK-T. But the Kane, then the SRK-T, giving the best results post-operatively. And if you want to calculate the astigmatism for cataract surgery in keratoconus, you should go at least for 2, either the Cassini, Keraton, Lenstar, Pentacam, at least 2. But in this study, they compare the 4 in this study, and there is a significant correlation between the total corneal astigmatism and the ACA, whereas the posterior corneal anterior corneal astigmatism, whereas the posterior corneal astigmatism can be predicted from the anterior corneal astigmatism measurement only. And also in this study, they concluded that the posterior corneal astigmatism can be variable in eyes with keratoconus and correlates with the total corneal astigmatism. I'm going to pass this also. So, high astigmatism or regular astigmatism, whatever you are going to do, you are going to leave an astigmatism. So they thought that if they put the monofocal or at least part of the astigmatism, they put the IOL, then they put the pinhole IOLs to decrease their post-operative astigmatism, or to make the patient does not complain of the residual astigmatism by this way or by the pinhole pupilloplasty, which I don't have this IOL in Egypt, but I do pinhole pupilloplasty in all my cataract patients with keratoconus. The results are very good. I'm going to highlight some intraoperative tips in cataract with keratoconus. You should know that early keratoconus, it's normal cataract, but in severe keratoconus, with a steeper meridian, the postable corneal skull can be troublesome. So when you choose where to go with your keratome, you should be away from the cone first. And the cataract main incision site should be planned during the preoperative examination on the slit lamp. You are going superior, upper temporal, or temporal. Very important to choose before the operation. Also, in the presence of corneal scarring, which is common in advanced keratoconus, the main incision should be placed 90 degrees apart from the scar. And also, well-constructed two-step sclerocorneal incision is advisable to reduce the risk of post-operative wound leak. And for me, I take a suture, even if I'm going for 2.2, I take a suture. Because this is a fluctuating cornea. Very small trick that in steep keratoconus or advanced keratoconus, if you put a viscoelastic on the cornea, it will going to regularize the view, enhance the view system for you. And this is what I'm said, the EMC. After marking the corneal incision, even in good read reflex, use staining of the capsule, because also you are going to find that there is a different reflection of the capsule. Staining make it more easy for you. So my take-home message, in keratoconic eyes, optimizing the IOL power calculation is certainly a vital importance to improvement of the surgical outcome. And in keratoconus can cause multiple sources of keratometric and biometric errors, especially in severe cases. To obtain the best outcome, surgeon must take an extra time to address the complexities of the cornea, utilize the best technology available, and make careful of preoperative measurement, adjusting the refractive target based on the calculation made with multiple formulas, best scan formula nowadays. In keratoconic eyes, optimizing the IOL pulp calculation is certainly of vital importance. Keratoconus can cause multiple sources of keratoconic. Okay, sorry. And just, I want to highlight this. This book, it was a huge work between me and Cosmo and 38 international speakers from east to west give everything about keratoconus, and we put a title for this book. It was Current and Future State of Art. I hope everyone can get this book. Thank you so much.
Great, thanks, Dr. Ashraf. It was a comprehensive, interesting lecture and presentation for cataract and keratoconic. So great, thanks for you.
Thank you so much.
Now we all know that this formula is working, but still, yeah. So always we are advising the patient and asking them that there is no a key for a 6/6 or an improvement of the vision in an unusual way. There is a high order of patients that we will not cover it, and there is a lot of surprises. Now, when we are saying the grade 3 to change the residual refractive from -2 to -3, just to overcome the hyperopic shift. And believe me, still we have a hyperopic shift. Anyway, we need to go to the last speaker, Dr. Kazimo, and he will talk about the things that having a lot of debate. The PRK cross-linking up to date. So when anyone talking about the PRK and cross-linking, especially the spontaneous, simultaneous, whatever you need to say it, or the sequential, the debate started. So you can see that one saying that no, it's sequential, and the other will say no, the spontaneous is. So let us see, Kazimo, what will say.
Yes, I stopped the video because we have.
And you don't know what I prefer.
You want to see the video? This is for an homage to Dubai. Okay.
He did it for me. Okay.
I don't know if. Okay. If you can have the volume of the video.
Just the volume of the video?
The volume.
I think that he needs to connect it.
Okay. It works. We have no difference to answer to you. Between three, sequential, postponed. So, cross-linking has paved the way to combine BTK or PRK corneal remodeling for these keratoconic patients. This treatment started about 15 years ago. We have more long-term data published in the literature, so it is not a novelty. The novelty is how to do the best way. Where we are, the indication, where cross-linking meets corneal remodeling with laser. We are in stage 2 general patients who has intolerant to contact lens and want to improve their visual acuity with spectacles correction. It is important, this is not refractive surgery, it is therapeutic surgery.
Still, when we are saying
Okay.
they are talking, they are saying.
We don't want to remove spectacles. We want to improve spectacle-corrected visual acuity, improving the quality of vision, regularize the corneal shape, reducing the corneal aberration, reducing the nocturnal fluctuations that these patients have with spectacles, consuming the small amount of tissue, giving a chance also for a new contact lens refitting, avoiding or postponing donor cornea graft. A lot of literature. John Canellopoulos started together with George Kimionis, first studies.
You can see that John Canellopoulos now disappeared. There is not,
Yes.
no one can see him now.
But this was a very good flow chart from George Kimionis published in the Journal of Cataract, a Journal of Refractive Surgery. And you can see that if we have a stable or stabilized keratoconus, or we want to stabilize keratoconus and to include also TPRK or PRK, we need first to prescribe to our patient contact lens. If patient doesn't tolerate, we can check if this technique is indicated. Take a look to long-term results. These are the 10 years outcomes. And the 10 years outcomes showed no adverse events, no complications, a gain in corrected distance visual acuity more than 2 lines, and uncorrected visual acuity in 45%. Despite these results, you can see how many protocols we have. The Athens protocol, the Cretan protocol, the CCR, the Topoliink from Israel, CCR Tel Aviv protocol, so the Sterix protocol we have published. So what I mean, there are some common points. 50 microns of stromal ablation generally in all the studies. Optical zones from 5.5 to 6.5. The minimum corneal thickness 435 average, from 300 to 450. Generally not in pediatrics, but patients, not pediatric patients, okay? Stage 2 and 3 borderline.
But actually that's the study was saying.
Take a look to this. We have a gain of average 2.3 lines, but take a look to the cross-linking protocols, each different. So we need a global consensus and guidelines, okay? To answer to your question, if indicated, even patients already cross-linked can be treated with topography-guided or wave-guided excimer laser ablation. So you can do simultaneously or sequentially. We don't have significant difference in this group of patients. You know that you don't use the Dresden protocol in this treatment. No Dresden protocol. You need accelerated protocols, pulsed light protocols to avoid and minimize AIDS. Which was the complication? The complication for the full anterior regularization was the overcorrection. In the literature, the overcorrection was reported. But thanks to ray tracing, finally, we can calculate the posterior surface, so we can avoid this kind of complication. I showed you this slide yesterday to show that if you regularize in full the anterior surface without taking into account the posterior contribution, you go in overcorrection. If you take into account the posterior contribution, you eliminate the small amount of coma to compensate the posterior surface, and you don't go in overcorrection.
And Cosimo, here, there's one important thing that the
Yes.
groups that they were against the treatment, they are just accusing that hyper or overcorrection because of the flattening, not because of the overcorrection.
Yes. If you take a look to these maps, this is the anterior retracing map, but if you can see the posterior, you need to regularize on only the small amount of surface. And you can perform this transepithelially. These are our studies. We have the paper in press. And these are the results using the ray tracing technology. You can see the pre and the post. The ray tracing is superior to all the other platforms, actually, to achieve the best spectacle corrected visual acuity and also the uncorrected. You can see the gain is 3.5 Snellen lines and corrected is 4.3. You can see here we gain more than 4 lines in about 70% of treated patients in correct distance visual acuity, in about 40% of patients for uncorrected visual acuity. We don't have any line loss. We gain 3 lines or 4. This is really important. These are all the data. You can see the Kmax reduction, the mean pupillary power reduction. These are the two groups, sequential and simultaneous. Of course, you can see we have no statistically significant difference between these two groups, so you can do both.
Yeah. Using the total corneal power.
These are some clinical cases. You can see the pre and the postoperative point spread function. You can see the retraced ablation. Again, another case, the pre-op on your right and the post-op on your left. Take a look to the point spread function. It's amazing. Take a look to this. But I want to show you, we have stability in the long-term follow-up. This is a 4-year follow-up, and you can see the minimum corneal thickness. But I want to show, in particular, the posterior corneal surface, the posterior elevation that I use as criteria to establish if these patients are stable or not. Take a look to the posterior surface. These are all long-term follow-up. So, another important thing, don't use mitomycin. No mitomycin in these cases after cross-linking, because you increase the probability of AIDS, don't reduce the probability of AIDS. And this was brilliantly demonstrated by Shadi Awad. So these are the indications. Thank you. Thank you very much.
Great, thanks, Cosimo. So here to summarize, sorry, yeah, please. Yeah, we can. So to summarize that the use of the laser and the cross-linking still debatable whether it's a simultaneous or sequential, but there's 2 important facts raised with the advancements of the technology for the tomography, that the total corneal power reduce all the consumptions of the tissue that we were using it to treat the anterior instead of the total corneal power, and the use of the mitomycin C was not a correct use because it was one of the causes of the haze or increase the haze, because one of the important issues is that hyperopic shift and the haze of the cornea.
Yes, because you stop the the myofibroblast to come into the state of keratocytes and to clear the collagen.
Exactly. Great thanks. So great thanks for everyone, and we will end up this session to allow for the next session to become. Thank you.